Okay, next section, the esophagus. The very first disorder that we want to talk about is a TE fistula, a tracheoesophageal fistula. Let's remind ourselves that a fistula is an abnormal connection between two tubes, and in this particular case, the abnormal connection is going to be between the trachea and the esophagus, and of course this is a congenital defect. Now there are multiple different variants, however, we're just going to focus on the most common variant and go through a couple principles. So in the most common variant, what we have a proximal esophagus that is atretic. Atretic means that it ends in a blind pouch or a blind loop, so we have proximal esophageal atresia. And then when you look at the distal esophagus, it comes off the trachea. So up here would be the trachea, and then you've got the distal esophagus coming off the trachea, and that's where the fistula is. There's a connection between the distal esophagus and the trachea. Now in this particular case, the clinical findings are all based on this anatomy. So once you understand the anatomy, everything is downhill. You can imagine that when the baby consumes food, it's going to go into this blind pouch and then it's going to shoot back up. So the patient or the baby is going to have vomiting. Another important feature of having this atresia of the esophagus is that remember that the baby floats around in amniotic fluid, and the amount of amniotic fluid is basically a function of two things. The baby produces amniotic fluid from the kidneys. Remember that the vast majority of amniotic fluid is actually the urine of the baby. And at the same time, the baby consumes some of that amniotic fluid by swallowing it. And when the amniotic fluid is swallowed, it then gets digested and goes through the GI tract. And so you can imagine that if the baby can't swallow amniotic fluid, they won't be able to remove some of that fluid physiologically, and hence there's going to be excess fluid. And that's called polyhydramnios, excess amniotic fluid. So that's a second clinical feature. The third clinical feature will be that as the baby breathes, air will come down into the distal esophagus and eventually go into the stomach, and so you'll get abdominal distension. And then finally, some of the contents from the stomach will aspirate back through the distal esophagus into the trachea, which will then give you aspiration. So there are 4 clinical features in this most common variant, and I've written this all very clearly in your text, so you should be able to follow it there. Here's an image of a TE fistula. It's a beautiful, gross picture. You can clearly see that this is the proximal esophagus, which is atretic. This is the distal esophagus here, and it's plugging into the trachea. And so this is, again, the most common variant of a TE fistula. Esophageal web refers to a mucosal protrusion that results in obstruction or a partial obstruction with dysphagia for poorly chewed food. Let me just draw this out again just to remind you. Let's say that that's the lumen of the esophagus there. Well, remember that the wall of the esophagus would contain a mucosa, and behind that mucosa would be a submucosa, and then behind the submucosa would be the muscularis propria, and then behind the muscularis propria you have a serosa. So these are the 4 key layers of the GI tract. And in this particular case, in an esophageal web, you get a protrusion of the mucosa, which then results in a partial obstruction, which is called a web. Now, of course, when the patient eats, especially if they have not chewed their food very well, so if you have poorly chewed food, that can present with a little bit of dysphagia because it gets trapped in this web. So again, an esophageal web is a thin protrusion of the mucosa only. It occurs usually in the upper esophagus, and it presents with dysphagia for poorly chewed food. There is an increased risk, as I've stated here in your text, for squamous cell carcinoma of the esophagus, but I'm going to make this very clear at the end of the lecture. So let's skip this point for now, but just bury it away in the back of your mind that in an esophageal web you get an increased risk for squamous cell carcinoma. The most important manifestation, at least for the purposes of board examinations, of an esophageal web is something called Plummer-Vinson syndrome. Recall from our discussions in red blood cell pathology, where we discussed this once before, that in Plummer-Vinson syndrome the patients have severe iron deficiency anemia, an esophageal web, and a beefy red tongue. Now that beefy red tongue is basically due to the fact that they get atrophy of the mucosa, so they get a little bit of atrophic glossitis, and the red color is actually because the blood vessels are exposed. The next disorder is called a Zenker diverticulum, and this is an outpouching of the pharyngeal mucosa through an acquired defect in the muscular wall. Basically what happens is you have abnormal pressure in the pharynx when you're swallowing, usually due to some sort of impairment or disordered swallowing, and so when this abnormal pressure develops in the back of the pharynx, then you get a protrusion of the mucosa through the muscular wall. So you can imagine it as such. If this is the mucosa here, this layer is the mucosa, remember that behind it is going to be this muscular wall. Now if there's disordered swallowing, you're going to generate some high pressure in this particular region, and then that's going to result in a protrusion of the mucosa through or backward through the acquired defect in the muscular wall. This usually occurs just above the upper esophageal sphincter at the junction of the esophagus and the pharynx, and it's and this is the classic location. Now patients can be asymptomatic. Perhaps the most common symptom that they can present with is that they feel like there's something in the back of their throat, but they can also have dysphagia, they can have obstruction, and they can have halitosis. Halitosis refers to bad breath, and the idea here is that as the food gets trapped in that diverticulum, it can rot, and when it rots, then the smell of the rotting food will actually come through the mouth, giving the patient bad breath. Important to note that when we talk about this Zenker diverticulum, this is also known as a false diverticulum. False diverticulum means that you've only protruded one part of the wall through the entire wall. So that's also called a false diverticulum, and most of the diverticulums in the GI tract are actually false diverticulums where part of the wall goes through another part of the wall. Mallory-Weiss syndrome is when you get a longitudinal laceration of the esophageal mucosa at the GE junction, and the idea is as follows. If this is the esophagus and you've got the stomach coming off the esophagus, of course here is the GE junction. Now basically in this particular disorder, patients have severe vomiting. As the vomit goes up, it also begins to create a linear laceration of the mucosa at the GE junction. So that's called Mallory-Weiss syndrome. Now, of course, because this is all driven by vomiting, the causes are going to be those that are associated with severe vomiting. And so the two causes or the two circumstances in which we usually see this are, number one, alcoholics or alcoholism because of the severe vomiting, and then bulimics who force themselves to vomit in order to try to decrease or maintain their weight. And so that's what would then result in this linear longitudinal laceration of the mucosa at the GE junction. The way this is going to present is that this laceration is going to bleed, and so the patients are going to have hematemesis, which is blood in the vomit. However, it will also be painful, and that's particularly important, is that these patients have, as I've stated here in the text, painful hematemesis. Now, there's a risk of something called Boerhaave syndrome, and Boerhaave syndrome is when you get rupture of the esophagus, so you can imagine that you can actually bore through the entire wall of the esophagus and get rupture. When you rupture the esophagus, you get air in the mediastinum. The air in the mediastinum can then actually track up through the fascial planes and eventually get into the subcutaneous tissue, especially in the region of the neck. Now that will then result in something called subcutaneous emphysema, where you actually have air bubbles within you can actually push on the air bubbles within or beneath the skin. And as you push on those air bubbles beneath the skin, you can actually hear a crackling noise, almost like Rice Krispies. And so when you press on that, you get that crackling noise, and that is a classic sign of subcutaneous emphysema, which again, that would be a hint that you've got some sort of a process leading to air in the mediastinum. And in this particular case, we would think about Boerhaave syndrome. So that's a very high yield discussion to be aware of. Esophageal varices are when you get a dilated submucosal vein in the lower esophagus, and this is going to arise secondary to portal hypertension. Let's remind ourselves of a little bit of anatomy. Remember that there are two ways by which the veins of the esophagus drain. Most of the esophageal blood actually drains via the azygous vein into the superior vena cava. But however, there is some of the blood that drains from the left gastric vein into the portal vein, so that some of the blood from the esophagus does drain into the portal circuit. Now, if there's portal hypertension, then we're going to have a backup of blood into the left gastric vein, which will also result in a backup of blood into these veins in the esophagus that were draining via this pathway. And so that would result in a dilation of those veins, and so that's again called esophageal varices. Dilated submucosal veins in the lower esophagus, of course related to portal hypertension. Now these are asymptomatic, so it's not too problematic. However, you've got to be very well aware of the complication, which is that these can rupture. And if they rupture, the patient's going to present with hematemesis, or the vomiting of blood. However, it will be painless. That's very important, because remember, when we talked about Mallory-Weiss syndrome, we said that the patients have painful hematemesis, whereas in esophageal varices, it's painless hematemesis. Now, this is very important to be aware of because it's the most common cause of death in cirrhosis. So patients who are cirrhotic obviously have portal hypertension, and the most common cause of death in those patients is rupture of an esophageal varice. And of course, the second problem that these patients have is that they have a coagulopathy. So because their liver is not functioning and they're not producing their coag factors. And so this can also complicate further the fact that you now have got a bleed without the ability to seal it. So most common cause of death in cirrhosis. Achalasia, A means without, and chalasia means relaxation. And so one of the key issues in this particular disorder is that you lose the ability to relax the lower esophageal sphincter. In addition, there's disordered esophageal motility, so that you lose motility as well. So these are the two key problems in achalasia. Number one, an inability to relax the lower esophageal sphincter, and number two, disordered esophageal motility. So basically the idea would be as follows, that if this is the esophagus, and of course the stomach is coming off the esophagus, you're well aware of the fact that in order to move food down this esophagus, both fluid and solids both require peristalsis of this wall. So that if you lose peristalsis of this wall, then the patients are going to have dysphagia for both solids and liquids. And that's one of the key clinical features in this particular disorder, is that the patients have dysphagia for solids and liquids because they have an inability, or they have a loss of the esophageal motility. The other problem in this particular disorder is that they've got an inability to relax that lower esophageal sphincter. Now, if they can't relax that lower esophageal sphincter, then what's going to happen is that food is going to begin to pile up as it comes in, and you're going to get massive dilatation of the esophageal wall. You can do barium on these patients, and this massive dilatation will fill up until you come to the point where there is this tightening of the lower esophageal sphincter. I shouldn't say tightening, it's actually an inability to relax. So there is this inability to relax the lower esophageal sphincter, and of course this whole angle here looks like a bird beak. And so they call that the bird beak sign on barium swallow. Now, it's important to note what's causing this disorder. The cause of this disorder is the fact that the patients have damage to the ganglion cells in the myenteric plexus. Now, let's go back and remind ourselves of a little bit of normal histology. And remember that when we talk about the lumen of the esophagus, remember that the wall of the esophagus contains a mucosa, and then behind that mucosa there's a submucosa, and then behind that submucosa there's a muscularis propria, and then behind that there is a serosa. Now the muscularis propria is actually made up of two layers. There's an inner circular layer and there's an outer longitudinal layer. And in between those two layers runs something called the myenteric plexus. The myenteric plexus is a collection of ganglion cells, and that collection of ganglion cells is essential for regulating both bowel motility and for relaxing the lower esophageal sphincter. So if you destroy these ganglion cells, you're going to lose both bowel motility in the region of the esophagus, because that's where it's occurring, and the inability to relax that lower esophageal sphincter. Now we should then ask the question, what causes damage to these ganglion cells? Well, as I've stated here in your text, the damage to the ganglion cells can be idiopathic or secondary to a known insult. And one of the classic associations is Chagas disease, where you can get damage of the ganglion cells via this infective process. Now here's the classic picture of the barium swallow, and what I'm trying to highlight for you here is the bird beak sign. It's a very pretty picture of the bird beak sign. This is the dilated wall of the esophagus, and this is where the lower esophageal sphincter is not relaxing. And so again, this would produce what we classically call as a bird beak sign. Now the clinical features of this disorder are all going to be based on what I've already explained. So there'll be a dysphagia for both solids and liquids, and again, you need motility to move both solids and liquids. They're going to have putrid breath, and that's because the solids are going to accumulate in the esophagus, and of course that food is just going to rot, and the rotting food will then create very bad breath. An additional finding will be that there will be a high lower esophageal sphincter pressure. Now the idea here again is that you've got this dilated wall, and then you've got tightness of the lower esophageal sphincter, so that results in a high pressure when you do esophageal pressure studies. And this is a very high yield association, and it comes up often on examination. So you need to know that the pressure and the LES will be high, and of course I think that makes sense if you understand the disease. The bird beak sign I've already talked about. It's also important to note that there's an increased risk for esophageal squamous cell carcinoma, but again, I'm going to touch on that when we talk about cancer, and I'll make that principle very easy for you. The next disorder is called GERD, and GERD refers to gastroesophageal reflux disease. Now the idea here is as follows, that what's going to happen is that you've got the esophagus and then you've got the stomach, and of course the stomach is coming off. This is the lower esophageal sphincter, and the lower esophageal sphincter in this particular disorder is not as tight as it should be. So there's a decrease in the tone of the lower esophageal sphincter. What then happens is that allows for acid and gastric contents to shoot up into the esophagus. When that acid and gastric contents shoot up into the esophagus, that then is going to change the stress on the cells of the lower esophagus, because now they're seeing acid instead of food, and when they see that acid, they then undergo a metaplasia to better deal with the stress. Now, so initially, remember that the cells that are lining the esophagus are non-keratinizing squamous epithelium. That's the normal lining of the esophagus, non-keratinizing squamous epithelium. But what's going to happen in response to this change in stress is that you're going to get a change in the cell type. The change in the cell type then becomes non-ciliated columnar cells with goblet cells, and that is then, of course, a metaplasia. Now let's go back and just review what we have here in your text. So, of course, we've already talked about the fact that you get reflux of acid from the stomach due to reduced lower esophageal tone. The risk factors are interesting. Alcohol, tobacco, obesity, a fat-rich diet, caffeine, all of these are risk factors. One that we should particularly emphasize is something called a hiatal hernia. So let's take a minute to just explain what the hiatal hernia is. Now basically, again, you should remember your normal anatomy, and that is that the esophagus is that plugging into the stomach, correct? And of course, we know that running here and running here is the diaphragm. And the diaphragm plays a particularly important role in helping to maintain that lower esophageal sphincter, by the way. Now what can happen is that you can get a diaphragmatic hernia in which the stomach can actually herniate up into the thorax. The most common type of diaphragmatic hernia is actually called a sliding hiatal hernia. And what happens in this particular case is that the stomach here herniates upward into the esophagus. And that's the most common type. Again, it's called a sliding hiatal hernia. Now this results in a couple things. Number one, you've now got a little bit of part of the stomach, which really here would be the cardia of the stomach. So the cardia of the stomach is up into the esophagus, and that's going to allow for reflux. And because again, you really don't have any sphincter now. You just kind of got the stomach pressing up against the esophagus here, and so that's going to allow for reflux, which would then increase the risk for gastroesophageal reflux disease, and that's the context in which we're having this discussion. Another important thing, and that's high yield for examinations as well, is that you're still going to have the little bit of tone here in the lower esophageal sphincter. The lower esophageal sphincter is normal when you have this hernia, and so this produces something called the hourglass appearance of the stomach with sort of a compression down the middle here. And so that's an important thing to be familiar with as well. Remember that there is another possibility when you talk about diaphragmatic hernias, and that is that you could actually develop this, where you've got the esophagus and then the stomach coming off, and then you've got the diaphragm here. You could actually develop a hernia such that the stomach actually herniates up next to the esophagus. That's called a paraesophageal hernia. All right, paraesophageal, because you're herniating a portion of the stomach up next to the esophagus. And what's important about this paraesophageal hernia is that it is, number one, much less common than the sliding hiatal hernia that I just described. And number two, the classic association here is that you have bowel sounds in the lung fields. So in the lower lung field, which of course here would be the lung, you would actually have bowel sounds in the lower lung field. And another important consequence of having this type of hernia is that this hernia, as it's present congenitally, will result in less space for the lung to develop, and so these patients can also have lung hypoplasia. Now I'm making a little bit of a diversion here. In this particular paraesophageal hernia, you wouldn't necessarily have GERD, but I just want to talk about this for completeness sake because it does show up on examinations. Anyway, let's go back to GERD and just quickly review. So what are we saying here? We say that there's reflux of acid from the stomach due to reduced lower esophageal tone. I've told you about the risk factors, and we talked about the hiatal hernia, in which the cardia of the stomach sort of balloons up into the esophagus, as I've already explained. Now, the clinical features are all based on the fact that you're shooting acid into the esophagus. So the patients get heartburn, which mimics cardiac chest pain. And so anytime when a patient comes in with quote-unquote cardiac chest pain, you do want to think about heartburn in the back of your mind as a possibility for that chest pain. They also present with asthma and cough. Now what's interesting about this asthma is that it is adult onset asthma. This isn't asthma that the patient has as a child, but instead what happens is they get new onset asthma as an adult. And so when you have adult onset asthma, you really want to think about gastroesophageal reflux disease. And the idea here, if this is the stomach and the esophagus coming up, as you get shooting of acid up into the esophagus, you can irritate the airway as well. And that can result in asthma and cough. The acid can also reach the level of the teeth, which would then cause damage to the enamel of the teeth. So that's a clinical feature. Now, some of the consequences of having all this acid shooting up into the lower esophagus is that, number one, you can get ulceration with stricture. Again, the idea being that if you've got the esophagus here and then the stomach coming off and you're shooting up acid, you can damage the mucosa so that it ulcerates. And then when you ulcerate the mucosa, remember that an ulceration is a complete knockout of the mucosa. So that if you've got mucosa and submucosa, when you get an ulceration, you actually are taking a divot out of the mucosa along with a little piece of submucosa. If you knock out the mucosa, you're knocking out the stem cells, and the way by which ulcers are going to heal then is fibrosis. So you can actually get fibrosis of this lower region here, and that can result in a stricture. And a stricture, again, is going to result in a loss of the lumen, or at least a narrowing of the lumen of the lower esophagus. So that's one complication, and that is that you can get ulceration with stricture. A second complication, and a very high-yield complication, again, is that when you have all of this acid shooting up, you're going to get the metaplasia that I've already described, and that's called Barrett's esophagus. This is a very high-yield point to be aware of. Here's a picture of Barrett's esophagus. I place it here because it's a very common picture to show up on exams. Here is the non-keratinizing squamous epithelium that normally lines the esophagus, and we've got acid shooting up and then hitting this particular portion of the lower esophagus. This entire slide should represent a normal esophagus, and you can see that the non-keratinizing squamous epithelium has ended abruptly, and all of a sudden we now have these columnar cells. And let me remind you that when you think about the metaplasia here, you get a metaplasia to a non-ciliated columnar epithelium with goblet cells. You got to know that entire phrase. Non-ciliated columnar epithelium with goblet cells. That's very important. And so here is this non-ciliated columnar epithelium with these interspersed goblet cells. Now, of course, this is a response of the stem cells to the acidic stress, and we've talked about this in detail in our metaplasia discussions. Because it's a metaplasia, it can progress to dysplasia, and that dysplasia could progress to adenocarcinoma. So that takes us into a discussion of esophageal carcinoma. But let's remind ourselves that esophageal carcinoma can be divided into two types, adenocarcinoma or squamous cell carcinoma. So in the case of adenocarcinoma, the most important things to know are that it's going to be a malignant proliferation of glands. Now, you don't normally have glands within the esophagus, and so the way by which it's going to occur is that you're going to get metaplasia, i.e. Barrett's esophagus, and which will then turn into an adenocarcinoma via the dysplasia carcinoma sequence. Now, of course, the only way to get this, of course, is going to be the metaplasia. Therefore, it's going to occur in the lower one-third because that's exactly where the metaplasia occurs. Now, what I can tell you about adenocarcinoma is that it is the most common type of esophageal carcinoma in the West. So that's the summary of adenocarcinoma. Most common type of esophageal carcinoma in the West arises from Barrett's esophagus, lower one-third of the esophagus. So once you understand the basics about adenocarcinoma, let's quickly review what I say in the book. I say adenocarcinoma is a malignant proliferation of glands, most common type of esophageal carcinoma in the West, Barrett's esophagus, lower one-third. Now, the second type of esophageal carcinoma is squamous cell carcinoma. This is a malignant proliferation of squamous cells, and it is the most common esophageal cancer worldwide. Usually arises in the middle or upper third of the esophagus. Now, the risk factors are interesting, and there's a long list of risk factors that we can go through, but let me just summarize this for you in just one word: irritation. If you irritate the squamous mucosa, you are going to increase the risk for development of squamous cell carcinoma. So let's talk about some of these and see how they irritate the mucosa. Of course, alcohol and tobacco are irritants. We are well aware of the fact that they irritate epithelium, and so they will irritate the mucosa and result in an increased risk for squamous cell carcinoma. Very hot tea. Places in southern China and Iran where they tend to drink very hot tea, there's an increased risk of squamous cell carcinoma in those particular regions. You find a relatively high incidence of squamous cell carcinoma in that part of the world. Achalasia can also increase the risk. Now, how's achalasia going to result in irritation? Well, you're well aware of the fact that the problem in achalasia is two things. You have disordered esophageal motility and an inability to relax the lower esophageal sphincter, so that the patients get this classic bird beak appearance of their esophagus. Now imagine that basically the esophagus is full of food, correct? And remember that the food is going to start rotting, and when it rots, that's going to irritate the mucosa. So this rotting food in achalasia is going to increase the risk for squamous cell carcinoma of the esophagus. Esophageal webs can also do it. Of course, the same idea. An esophageal web is a protrusion of the mucosa, which then results in a blocking of food, particularly when it is poorly chewed. Now, of course, food is going to pile up along this web, and when food piles up along the web, it's going to rot, and when it rots, that then is going to irritate the mucosa. So there's going to be an increased risk of squamous cell carcinoma. And the last risk factor is esophageal injury. Any patient that has had severe esophageal injury, for example, lye ingestion. Lye is a chemical that can be used to straighten hair, and so this chemical could be taken, for example, by a child by accident, which would then injure the esophagus, increasing the risk for squamous cell carcinoma. Now, important about esophageal carcinoma, whether it be squamous or whether it be adenocarcinoma, it presents very late in the course. The patients get progressive dysphagia. What does progressive dysphagia mean? Progressive dysphagia means that the dysphagia starts as dysphagia for solids and eventually progresses to dysphagia for both solids and liquids. So here's a picture of the esophagus, and you can imagine that you're growing this tumor in the esophagus. So initially, the solids are going to have trouble passing that tumor, but eventually the tumor is going to become larger, and as it expands, that's going to then result in dysphagia for both solids and liquids. The patients will present with weight loss, which is a classic finding in cancer. There will be pain, and there could be hematemesis. Of course, as the cancer grows, it's going to expand and stretch the mucosa, which would result in bleeding and blood in the vomit, or hematemesis. Now, in the case of squamous cell carcinoma, we should additionally recognize that these patients can present with hoarse voice and cough. And the reason they can present with hoarse voice is because the tumor is up in the upper part of the esophagus, and that can result in invasion through the wall into the recurrent laryngeal nerve. And you can also get invasion through the wall into the trachea, which would then present with cough. When patients have esophageal carcinoma, the cancer will, as it grows and eventually picks up additional mutations, can eventually metastasize. And it's important to note there are different regions of lymph node spread based on which part of the esophagus we're in. So this gets back to a little bit of anatomy, and so examiners like to go after it because it's an anatomy tie-in. If the cancer arises in the upper one-third, it tends to spread to the cervical nodes. In the middle one-third, you'd expect it to spread to the mediastinal or tracheobronchial nodes, and if it's in the lower one-third, you'd expect it to spread to the celiac or the gastric nodes. And that's important to note again because it's an anatomy tie-in. So that concludes our discussion on esophagus, and our next section will be on the stomach.